So if we look at a couple of case studies to kind of help illustrate the point, and these, and Harry, I'll call on you, if I may, when we get to Alberta Children's for some of the detail. So these are two projects that have retrofitted for airflow setback control to existing systems. And it is a very valuable thing to do in terms of the economics and the energy savings, and in terms of upgraded monitoring that it gives you the assurance things are running properly. But it's not straightforward to do in installed systems when the die is cast and the ceiling is full of stuff, and you have to deal with practical realities. This one we've touched on before at North York General. Alket and Simba were hoping to be here to talk to this, but this is a project that our team put together, so we can run through this back in 2017-18. The pictures of these things look a bit like this. In most cases, you should have ductwork layouts, drawings of the way everything is laid out. So the goals were not just energy savings and emissions reduction, because this was funded with Ontario carbon dollars, but there were significant pressurization issues that were resolved as a part of this. Upgraded monitoring was important, and to set the stage for doing more work in future around energy reduction as part of their ongoing program. The scope of this work, I was directly involved here, was in 8 operating rooms. The access into the ceiling, the space in the ceiling, only allowed for 4 exhaust dampers, so we had to zone the rooms. We couldn't shut them on and off individually. We had to deal with zoning, so it wasn't perfect, but it was practical. And I'll touch on lessons learned in a moment, that even that might have been more, we might have done a bit less and got most of the savings without creating complexity. But upgrading sensors, having one operating room that was designated 24/7, and they were comfortable with having that one designated as opposed to being able to move around between them. The rest going under setback control, and a significant amount of work around rebalancing between the ORs and the sterile core, and sealing significant air leaks, especially around the autoclaves that were preventing pressurization in the first place. So a fair amount of foaming insulation, identifying where the leaks were, where the gaps were, and closing those off, which improved the overall pressurization picture. And once this is up and running, it's always fun looking at the trend logs. So you can see immediately for a typical controlled operating room, this is what the unoccupied periods look like. They change from day to day and from week to week, but during those periods are the times when the airflow can be set back. Running through that, this was the designated 24/7 system, so you get the occasional little blips on the control, but it just runs open all the time, as it should. And the others do what we're looking for here in terms of dropping down to, I think, around 70%. Around 70% of airflow during the quiet periods. But you can see every day and every evening is different, but the occupancy sensors are picking them up. This was after commissioning, and things were running smoothly. Before commissioning, it looked a lot more like this, that tuning the occupancy sensors, tuning the controls to get to the point that they would run smoothly was a significant challenge, and was well done, and now the system works as intended. Lessons learned, and again, this is the kind of punchline in terms of how to prepare for this kind of project in future. If we had to do it again, we would have done a bit more upfront consultation around what is the relative advantage of going to more and more levels of detail control compared to the added complexity. And in other words, getting the first part of control there delivers a significant share of the savings, and then is incrementally less going through. So the optimizing the overall design, we wish there had been time for a bit more conversation, especially with Smith and Anderson, that were were helping with the design work and with the air testing contractor, that would have been useful. Spent a fair amount of time verifying where the ducts actually were and how much space was up in the ceiling. And I think everybody on the line knows how uncomfortable that process can be as you're disturbing the dust of ages above the ceiling line. But very important to know where you're at, because you've only got a limited amount of time to do the retrofit, and you have to get in there and out of there readily, and you can't find that things aren't the way that you expected them to be. We were very happy with the team walk through with the controls, the air testing contractor, the engineer, and the mechanical contractor in advance to make sure that everybody was well prepped. Again, if we'd had more time, we wish we'd had more, we'd conducted more communication with both the surgical staff, but also the cleaners. And only after the fact did we find that, in fact, they used the space rather differently than we thought they did. And one of the doors where we didn't install a door switch was the one they used most often. And so we had to go back in. Not a big deal, but communication with staff, we think, is a critical success factor for these kinds of projects. North York General has a great set of operators. They're excited about this stuff. And I think we did well in investing in telling them about the why, not just the what and the how, but the why of what's being done and how it works and what the principles are. And they seem to just absorb that stuff and run with it. And again, allowing time for rigorous measurement, verification, and commissioning after the fact to make sure the system's actually doing what it was intended to do. So interesting case study. In the end, the whole project cost was around $110,000, and it delivered a bit better than a 4-year simple payback. And from North York General's standpoint, again, it gives them far better monitoring and greater assurance that they're providing safe operating conditions for patients and for staff working within that space. So one of the lessons, one of the case studies, and talking with Harry and his colleagues at Alberta Health Services, Alberta Children's is another one. And if I may, Harry, I'd ask you for some of the color commentary that you discussed with us. But the essence there, and as Amandeep's discussed it with Franz, was once again, let's get occupancy control on individual ORs and achieve energy savings. Correct me if I'm wrong, but it was primarily an energy reduction project. The practicalities of what was done here, but are kind of listed out. I don't need to read them. But Harry, as this worked out, there were a few special factors that made it more cost effective to do it when you did it back in 2015. Is that correct?
Yeah, they happen to be doing a Wi-Fi project at the same time. So we were able to utilize that existing contractor to kind of piggyback access to the space. Because for us, especially, this is our only children's hospital in Alberta. Access to the space is usually the hard part. So that was already being coordinated because of Wi-Fi. So basically, we just kind of got in there to had the same contractor install the occupancy sensors.
And for the purposes of everybody else on the line that's considering now, maybe apprehensively, undertaking a project like this, was there any other lessons learned over the course of that installation that you'd want to pass on?
Well, we were following the CSA recommendations, and there's always kind of resistance from clinical people because there's the assumption that more is better. So just trying to convince them that, you know, the numbers that are in the CSA handbook, the 20 and the 6 at the time, were already had enough contingency in there that we did not need to put contingency on top of contingency. And just kind of from their perspective, they're worrying, well, what if you fall under the 20? So it's probably be better to be 22 to 24. So, and of course, every personality is different too. One of the other challenges is, of course, you talk to somebody on the day shift and somebody else on the night shift because there's so much turnover, not so much in these staff, but when you deal with different people. And on the clinical side, they don't always communicate with each other what's going on either.
And physically, the Alberta Children's is a much newer hospital than North York General, but generally was the access to space, was that reasonable for when the contractors were doing their work?
Yeah, that wasn't really a problem.
Okay, that's good to hear. And you know, Franz and Amandeep just started kind of looking at some of this, but the purpose of this is more, you can see the actual OR occupancy on the chart on the bottom, and what's happening to the fan kilowatts there. And as the fan kilowatts go up and down, so the cooling energy, the reheat energy, the preheat energy, humidification, all those numbers fall around in accordance. And I know, Amandeep, you're planning to have further conversations with Franz about is this exactly as it was intended, or is there room for further improvement? Looking more at the kind of the longer term and the bigger picture. This is the kind of trend logging that would be specified as part of doing one of these retrofits. I think there's not very long archiving there, Amandeep, is that correct?
Yes, for now, I think Franz mentioned it's only 7 days, but I guess the original project was expected to archive the data for 60 months. So that was in the original scope.
Okay. Okay. So again, this wealth of data that both allows you to make sure the system is operating as intended, and also to assure the users of the space that things are running as intended, is immensely valuable. So again, that should give a sense of a couple of examples, one of which mechanically in an older hospital was quite challenging, the other one relatively straightforward, and always the interface, the dealing with the users and making them happy that you're in fact giving them better environmental conditions, not worse, as this work unfolds. So those are a couple of examples of case studies where we'll be pulling more together as we kind of consult with the Greening Healthcare membership hospitals that have, again, acute care, ambulatory care facilities, and looking to enrich the story with as much practical guidance as we can, so that everybody taking on a project like this is doing it eyes wide open. But for reference, and again, we'll have the panel discussion a bit later in this webinar, but there is nothing, there are no projects that can be taken on that have such significant energy savings potential, because OR systems are so intensive, and that justify the amount of effort, again, to ensure that that post retrofit they actually run better, at least as well as, but ideally better than they were before, with a greater assurance that you're giving people the environmental conditions that CSA demands and that they expect within the space.